So our quality and safety project is based off of a pediatric burn case study. The overview is that we had a 2-year-old girl admitted to the burn unit with 10% total body area burns on the face, the chest, and the back. Um, Routine analgesia was used with around-the-clock acetaminophen, as needed NSAIDs, and oxycodone dressing changes every 3 days. All previous dressing changes were tolerated well with the oxycodone. On day 6 in the hospital, the patient received 3 doses of oxycodone within 8 hours of each other, one for pre-procedure, one post-procedure, and then again at 1700 hours. The mother found the patient to have shallow breathing, and the patient was lethargic and difficult to arouse and was found to be hypoxemic. A rapid response was activated, and ABG showed that there was carbon dioxide retention and hypoxemia.
So the physician, and then the error identified in the outcome, the physician reviewed um, just an unintended overdose. So the oxycodone was supplied at a higher concentration instead of the normal concentration that's given in the pediatric unit. So the dose that was delivered was actually 5 times higher than ordered, despite the nurse following the previous medication schedule. And then what they did was they administered naloxone, and there was a rapid improvement here, and they were able to avoid intubation. And then afterwards, the patient was monitored for 1 week, and then they were safely discharged home.
All right, so in addressing some of the potential cause and effects of how this situation happened, as we've done previously in class, we talked about kind of the 5 whys to break down what happened. Where could this problem been caught beforehand? And so, as you can see in the fishtail diagram up in the top, there's a few different contributing factors to this medication error. So as far as people go, the people that were involved were the nurse, the pharmacist, and the pharmacy tech, whoever was stocking the medications on the unit floor, as well as the physician who ordered the medication and the timing of it. Materials was the oxycodone with the incorrect dose. There was a lack of tracking the patient's vital signs throughout the medication administration. Otherwise, this respiratory distress would have been caught sooner than after 3 doses of oxy. Then as far as methods, not double checking the right dose, as far as on the nurse's end, not stocking the peds dosage on the pharmacy tech's end. In the environment, it was on a burn unit. It was not on the pediatric specific unit. And then with equipment, it was using this automated dispenser. And so a few of the why questions we identified were that why did the patient receive 5 times the amount of ordered oxy? Well, the nurse didn't check the concentration before administering it 3 times. Why not? She didn't do her 6 rights for the medications, and the automated dispenser didn't stop her from removing that much oxy in that short of period of time, which also should have happened. Why did this occur? Well, either the safeguards weren't working or the order was incorrectly entered into the dispenser. And beyond that, the incorrect concentration was stocked in the dispenser. That was due to the pharmacy tech having loaded it with incorrect concentration. And why did that happen in the first place? Well, they must not have double checked on their end as well. So there was a lot of steps in this process that this med error could have been prevented at. But as we can see, the root cause we identified was that overall there was just a lack of double checking, both at the very beginning with the pharmacy tech not double checking either the correct dosage into the computer or not entering the correct dose into the correct spot in the Pyxis or the automated dispenser. The nurse did not double check the orders. She just assumed that what she did a few days ago was still standing and that it would still be the same situation as previously. And then she did not double check the medications after she had pulled them out of the automated dispenser, any of which, at any point in that process, this medication error could have been avoided if those double checks had occurred.
As Micah was saying, we had four steps in the process, or five, where we could have ensured that this problem did not occur. This chart basically says the likelihood of occurrence, likelihood of detection, and severity of the error, and then those are multiplied into a risk profile. I determined that the highest risk was that our scan did not alert the nurse that the concentration was too high. I figure that human error is bound to happen, but our systems need to be able to catch our human error. And that's why our risk profile for our equipment usage was the highest error. But that being said, all of these are very high numbers in the risk profile. And the fact that all four of those happened for this med error to occur indicates that we have some work to do in order to ensure that this doesn't occur again.
Okay, perfect. So for the QI flowchart, we decided to focus more on the nursing aspect of the flowchart because at the end of the day, it's going to be the nurse's final responsibility to make sure the medication they're giving is what is what is prescribed. So the flow chart starts with identifying the need for medication administration. The nurse would then check to see what medication is prescribed in the chart, and then see if it's available in the machine. If it's not available in the machine in the right dosage or it's just not there, then they need to contact the pharmacy for the correct medication. If it is available in the machine, they should do their checks from the chart to the machine, whether or not it's the right med, right dose, and the right time. And if that is not correct, then they need to recheck what's in the chart or recheck the medicine and go back to the machine. But if they do have the right med and all that's right, then they can pull that correct medicine, and then there's the final check at the bedside when they need to do all 6 rights of medication, comparing the physical label on the vial of medicine to what's in the chart and what's prescribed. And doing that will hopefully prevent errors. So if that's not done, then they need to go back to the chart and the machine and pull the correct medicine. And if it is done correctly, then they can administer that medication.
All right, so here's an overview of our PDSA worksheet, our plan for improvement. So our objective here is to test a standardized barcode recognition scanner in the med room for high alert meds that will alert the nurses to incorrect medication, doses, concentrations, and so on. So our plan is that one nurse on the pediatric burn unit will test this barcode scanner for all high alert medication administrations during a single shift. And during the test, all high alert meds will also be double verified with another nurse to ensure accuracy and compare it to the barcode scanner. As for collecting the data, we will note the number of high alert meds scanned during the shift, the types of alerts that are generated, the time added to medication preparation, and any errors that the scanner catches. So onto the do, or in other words, what happened. The nurse scanned 5 high alert medications during the shift, and the scanner generated 1 alert indicating a concentration mismatch for a vial of oxycodone. So the nurse confirmed the alert with another nurse, notified the pharmacy, and the incorrect stock was replaced. And we also noted that this scanning added about 15 seconds to med prep time per high alert med. As for our study, or what we learned, the barcode scanning did successfully identify an incorrect concentration and prevented a potential overdose, which is great. And the impact on efficiency was minimal, and overall it seems to be worth the change. So finally, as for our action, what we should change going forward, we think that we should expand pilot testing to additional nurses on the unit over the course of 1 week and collect data. And it's also important that we collaborate with nurses and other staff on the unit to get their input. And assuming that continued testing is accurate and that we have good input from staff and other nurses, then we'll develop a standard practice to implement this on our unit.
So our plan going forward with this is to prevent future opioid overdoses in pediatric patients. And we want to do that by strengthening medication safety systems and also reducing the reliance that nurses have to get everything right the first time through their individual memory and vigilance. So some key actions that we can do to make that happen is implementing mandatory barcode scanning as in our PDSA worksheet. We want to do that for all high alert pediatric opioids just to verify that they are the correct dose and the concentration. Also, we want to implement independent double checks by the pharmacy and nursing staff for stocking and administering opioids. So pharmacy, we could perhaps have like another pharm tech just come in and look at what's going on, what's going into the automatic dispensing machine. And for nursing, an example of that could just be like independent double checks just right before like you would do like insulin or any other high alert med. We also feel like it could be helpful for the nurses on the floor to standardize pediatric opioid concentrations and then routinely audit the ADMs. So if all the nurses on the floor are educated on what, like a standard, normal, so to speak, opioid concentration is for a child, then they'll be easily be able to recognize what the mistake is. We also want to reinforce the 6 rights of medication administration with emphasis on concentration verification. This can be done through teaching, simulations, just anything outside of the workplace that can help teach nurses on the floor about that. Also, we want to reduce distractions just during medication administration by putting, the med room in like a place that's a no interruption zone, perhaps moving the ADM machine into there as well so that there are no distractions there and the nurse can focus fully on administering the medications. The expected outcomes of these points would be to hopefully reduce medication errors, detect earlier detection of stocking issues, and then also improve pediatric patient safety through these system-based safeguards as well.